So now you know what an AV block is. Now we're going to look at how to differentiate which type of AV block we have. So again, an AV block is a incomplete or complete miscommunication between the atria and the ventricles, and it's all because of the AV node. So one thing we're going to look at, the first one, is a first degree AV block. So what is a first degree AV block? So with a first degree AV block, all components of the cardiac cycle, from the SA node, send that signal over the internal pathways and Bachman's bundle, to it receives the AV node, to that transmission down to the ventricles to the Purkinje system, is all intact. One major component of that is the length of time that the AV node holds on to that impulse from the SA node. So normally that SA node sends the impulse, again, goes over depolarized atria. The impulse makes it to the AV node. The AV node holds on to it momentarily to allow for atrial kick. And then, so that time frame, so that PRI from beginning of the P wave to beginning of the Q wave, or R wave, should be less than 0.20 seconds, or one big block. So all this is still, if you take a sinus rhythm and extend that PRI to 0.120 seconds or greater, then we have a first degree block. So despite its name, the sinus impulse is not blocked. All sinus beats are conducted, which is one reason a lot of times we identify these as sinus with a first degree block. So the whole conduction cycle for the sinus mechanism is working. SA node, atrial depolarization. It goes to the AV node. AV node holds on to it just a little bit longer than what it should. And each time it is holding, each cardiac cycle is the same amount of time that AV node holds on to it. We just have a delayed release from the AV node to the ventricles. So the impulses are delayed for the same period of time before they are conducted to the ventricles. So this results in a PR interval that are more than 0.20 seconds in durations. So one big block. So if you're looking at the QRS complex, looking at the PRI, so one word of advice is, if your QRS complexes line up perfectly with the larger, darker line on the ECG strip, look at that P wave. Is that P wave, does it start before that preceding darker line, or does it start within those two lines? So if it exceeds it, we're greater than 0.20 seconds. So that's just a little word of advice. Instead of having to measure each one and take out calipers and everything, just real quick, down and dirty method, look at if you can find the QRS complex that lines up with a darker line on the graph paper, look to the preceding one and see if your P wave starts before or after that line. So, how do we recognize it? You take sinus rhythm and add a prolonged PRI to it, and you have a first degree block. So usually your first degree AV blocks are going to be within normal limits, but it depends on the underlying rhythm itself. The rhythm's usually regular, and P waves are normal in size and shape. So all the P waves look alike. They're upright, they're smooth, rounded, they look like sinus P waves, except so there's no changes there. There's no change with the QRS complex. But we do see a change in the PRI or PR interval. This is going to be prolonged greater than 0.20 seconds. And the QRS is usually within normal limits, 0.10 seconds or less, unless there's an intraventricular conduction delay or like a bundle branch block that's occurring. So here we have, so this is what I was trying to just mention on if your QRS complexes line up with a darker line, which there's our darker line, notice this QRS complex lines up pretty well perfect with that. Here's 0.20 seconds right there. Here's our beginning of our P wave. So notice we're already exceeded that. So we have one P wave for every QRS, 1 P wave for every QRS, 1 P wave for every QRS. So 1 P wave, one QRS, narrow complex, rhythms regular. The only difference is our extended PRI there. So by definition and by rules, we have a first degree block, or in this case, a sinus rhythm with a first degree AV block. So what causes this? So sometimes it may just be a normal finding. I mean, you're very seldom are you going to find out that patients calling you because they have a first degree block. It's just something that we find. Some people don't even know they have it, and it's just happenstance that happen to be placed on a cardiac monitor. But maybe a finding, normal finding in individuals, no history of cardiac disease. It just happened to find it, and they're living healthy lives and no problem. But there may also be occurring because ischemia or injury to the AV node or junction. May be from medication therapy, it may be from rheumatic heart disease, hyperkalemia, acute myocardial infarction, increased vagal tone. So all these are possibilities. Now, while it may be normal, and we're finding this for an unrelated circumstance, but if they're having any of these problems, we suspect ischemia, acute coronary syndrome, anything of that nature, it is worth exploring a little bit more because that may actually progress to a worsening block. So usually no symptoms are related to this, the first degree AV block. Our treatment is going to be geared toward their initial complaint. Now, if again, they are having chest pain or acute coronary syndrome or an MI or anything of that nature that we need to be managing, then we're going to manage that, but there's nothing specifically to do with the AV block. It's just a first degree block, atrial kick still in play. Usually these patients, by the rhythm itself, are asymptomatic. They may be symptomatic from their other complaints. So in the setting of an MI, monitor patient closely for increasing signs of block. So again, that may be what's fine right now. If we suspect they're having a cardiac related event, then, and especially ischemia is associated, that could worsen the AV block. It may lead to a second degree or even a third degree block.